Hey, happy Friday, everyone. It is Friday, October 30th, which means the day before Halloween this year. And I'm running a couple minutes behind because we had to celebrate. We are at our Reactive West LA location. We were all neurons. I'm at home on telehealth today, so they dressed up the iPad stand as a neuron down in Reactive Torrance. We were all of the emotions of 2020, so great. And today I'm hopping in here really excited to chat a little bit about 3PD. So my name is Julie Hirschberg. I am the owner of Reactive Physical Therapy and Wellness in the LA area with two locations, as I mentioned, two Halloween costumes. We are in Torrance, we are in West LA, and we do a lot of education with other therapists to share what we're learning and doing and to share a lot of hope for some of those lesser known neurologic disorders. So that's why we're jumping in today. And it has really been a whirlwind of a week, right? And the weekend. So I'm a huge baseball fan, huge Dodgers fans. They won the World Series over the weekend. That was a really big deal. We also opened the doors, launched our Brain Bite community opening for the second time. We had a really great response to that, and a lot of people joined, which I'm so excited about. And already we had our first session for the new group last night, and boy, it was so great. We had Natalie, one of our therapists, working with somebody that she sees with a musician's dystonia. And just to have a whole group of people brainstorming together and thinking about it and looking about it differently, it was just phenomenal. As part of, well, as our Brain Bites, as part of that, we have also been able to raise over $16,000 for our nonprofit for pro bono services at Reactive. So that's amazing. I can't even tell you. We started working through yesterday, basically transferring over all of that to cover people's needs. And we're starting people in therapy this week with that, with those funds. So thank you so much. I think it's really, truly amazing. So I'm getting back today out of all of that craziness of relaunching Brain Buys, getting through a World Series. We hosted a boot camp in the meantime, and just getting back to some of our regular stuff, which is sharing what we're learning and love doing with you all. Today, we're talking about dizziness, and in particular, functional dizziness, which is 3PD. And we're chatting about it because we've been putting a lot of work into it. Brittany Charlet, one of our physical therapists, and I just met yesterday to start putting together some of our cases for our course that is next week. We host mini courses as part of our fellowship, and we've got one next week. And I've been pretty obsessed, I have to say, with 3PD for over a year. I'm seeing it more and more in our clinical practice. And so I wanted to share a little bit about what it is. How do we know somebody has 3PD? So, what are those diagnostic criteria? And finally, most importantly, why there is hope for recovery with treatment. So, really excited to share those things with you. So, first, let's talk what is 3PD and why do we even call it 3PD? Because it's so hard to say all of these P's together, but it stands for persistent, postural, perceptual dizziness. So, 3PD. The name itself really helps us to understand what it is. It's dizziness that persists, so it's persistent. It's related to motion and posture, so typically with an upright posture, so it's postural. And it's perceptual, so there is a perceived motion, especially within the body, perceived sense of imbalance. And that's where we get our P's. So this fits under the realm of functional neurologic disorders, which we talk a lot about at Re+active. It's a functional vestibular disorder, and it's characterized by long-lasting, so persistent dizziness that's non-spinning, meaning it's not the world spinning dizziness, but often an internal sense of spinning or rocking or motion. That's how people usually describe the dizziness. There's visual and motion sensitivities or hypersensitivities. There's a lot of that perceived imbalance, unsteadiness on the feet. Now, what is very true about this disorder is that it's often triggered by a very definable onset of a vestibular disorder. So people might get this after vestibular hypofunction or BPPD or Meniere's disease. So it can be triggered by an actual peripheral disorder. And part of the management is ensuring that has been resolved, or is no longer an ongoing component of the dizziness. The dizziness might also be triggered by a panic attack. So that could be another initial onset of the dizziness. So one of the things that's growing, just like the other functional neurologic disorders, it's been recognized more and more. And it's probably, as they've been able to recognize it more, one of the more common causes of persistent dizziness, maybe about in that 15 to 20% realm. So it's common. And honestly, the world just needs to know more about it, which is why I'm here. So how does a person know? How do we know if somebody has 3PD? So now there's great, clear diagnostic criteria. So they start with dizziness, unsteadiness, or that non-spinning vertigo present on most days for 3 months or more. So that's that persistent part of it. The symptoms, so it's most days, right? So it's not episodic. They're usually for prolonged periods of time, but they don't have to be continuous through the whole day to have those symptoms. So that's number one. Number two is that the persistent symptoms are present without a specific like provoking factor, but can be exacerbated by things. So upright posture is one, active or passive motion is another. And then the third is exposure to moving visual stimuli or really complex visual patterns. So this is where people will say, whoa, the grocery store, or oh my gosh, when I'm driving, when I'm in a really busy place around a lot of people. So that's the second. The third is that it's often triggered by events that cause vertigo, unsteadiness, dizziness, or problems with balance. So things like acute, episodic, or chronic vestibular syndromes, other neurologic or medical illness, or like I mentioned, psychological distress. What's important, just like the other functional neurologic disorders, it doesn't have to be, and it doesn't have to include psychological distress. So it can be from many different areas. So the next piece of the criteria are symptoms cause significant distress or functional impairment. That is most certainly true. And the symptoms aren't better accounted for by another disease or disorder. So there's certainly things that need to be ruled out when somebody has a complaint of dizziness. So that's what 3PD is. That's how it gets diagnosed. When we have our course, we're going to talk about how we go about assessing things, but I really want to talk here about the hope for recovery, because recovery is possible. And the literature is starting to grow in this area. Most things are in small trials. They may not be randomized. And the literature is coming from various places. So one particular area is in a real three-pronged approach where it's integrated vestibular rehab, the things that we do, medication, and cognitive behavioral therapy. So this is one area that's been studied. And here's the hope. The combined approach has shown a 78% reduction in dizziness that's sustainable for 1 to 3 years at follow-up. So that's pretty awesome. I think that's great, especially when a person has been really dizzy and feels like it may never go away. There's hope for recovery and complete recovery too. So in that three-pronged approach, by the way, we're gonna hit heavy on the vestibular rehab part of things. Medication may be a part of it, and it really depends on the severity of the 3PD, how long a person has it. And I know many people I work with are adverse to taking medication. So it's a very much a person dependent piece. But one thing with the medications is that they kind of open up some of that neural pathway, decrease some of the excitability in the nervous system to lay down the neuroplasticity to improve somebody's ability to balance and remain steady without dizziness. So that's one part of the approach. Psychology can be another huge part. So anybody, I mean, I've had a vestibular hypofunction. I've had BPPV. It is really scary, right? So when you get up and move, and all of a sudden you fall over, you're running into walls, and feeling really, really dizzy, your nervous system automatically starts going into protective mode. It's normal to do that. Your muscles might tense, you might move really rigid. I know I found that when I had an acute vestibular episode. One of the things that really helped me when I had that episode is I knew what it was and I knew how to respond because this is what I do. And I went to a therapist right away and they helped me get along that path. So that really kind of kept me moving and recovering without going into a more persistent state of dizziness. When some of those pathways get laid where there's a lot of fear and then a lot of, oh, just like hypervigilance. Is it there? Is it there? What's going to happen? It can really ramp up anxiety. And having somebody to support and help you with that from the outside, a really great psychologist, psychotherapist can be huge. And the literature has shown this to be very effective in 3PD. It does not mean that it's in your head or that it's a psychological disorder by any means. It does really signify, though, that those pathways, the interactions for anxiety, balance, dizziness, our head and eye control, they're so interrelated that we really do need to address all of the pieces of it. So, three-pronged approach here: medication, psychology, and most importantly, I would say the vestibular rehabilitation. And we can take pieces of some of those studies in cognitive behavioral therapy and really apply that to our interventions as we look to desensitize the system to visual motion, for example. So that's something that I find particularly effective when we look to provide distraction and more actually difficult tasks sometimes in order to decrease some of the hypervigilance. So we're using some of those techniques of exposure. So let's talk about the hope with recovery with vestibular rehab. Again, small pieces of literature here, but we have seen that people can improve with visual and motion desensitization, progressive habituation, normalizing some of the sensory and balance responses, and even working on some of the trunk stabilization, helping to normalize, improve balance confidence, lessening fatigue, lessening some autonomic dysregulation. This is a really big piece that we'll do because it really can trigger things, and progress somebody's fitness. And, when we look at some of the models that have been proposed, by the way, I'm a huge fan of Janine Holmberg and her work here, and she had a really great article reviewing these pieces. The cornerstones of successful treatment include a lot of education, a lot of the autonomic regulation and grounding, so that we can move through some of that slow progression of desensitization and keep grounding and keep coming back to grounding. That's a big piece of the therapy. And balance training. So proprioceptive up training, vestibular up training, because there looks to be a misweighting of sensory information. And honestly, here's another great thing for hope. It can be progressed through a very short amount of therapy. So often if it's addressed really early, so within weeks to months of onset, that can be, 3, 6, maybe 8 therapy sessions. So it can be, you can come to a sense of recovery in a short amount of time. Now, if the 3PD is pretty ingrained, so meaning it's long-standing or really complex, so a lot of comorbid issues, um, they that can really lead to needing more time. And actually, we talk about this in our course, and Brittany Charlie and I talked about this a lot. Um, Yesterday, she had a case where it was really, really ingrained, and it just took a long time and a lot of therapy, but that person got back to work, which was just really hopeful and exciting. So I wanted to share with you one of the things that we frequently use is our river runneth over analogy when we talk about therapy and really building up the person's nervous system so that they can they can be aware of the things that might be contributing to an increased level of dizziness. What we're doing in the vestibular rehabilitation realm is we're digging a wider river, we're building maybe temporary sandbags, but really helping the person build up a wall so that the river holds more water and to minimize this overflow, which we would see in dizziness. So I use this a lot. I love it. We're making a workbook. We have a functional movement disorder workbook, a dystonia workbook, and a CRPS workbook. So we're making a 3PD workbook for our course and including the river runneth over because I love it so much. It's a great way to incorporate all of the pieces into a person's recovery. So I'll put in a link because you can download our River Runneth Over if you want to try this as part of your educational piece. And I'll put in a link to our course if you want to join us next week. But thank you so much for joining me here on a Friday to talk about a disorder that is really important, not always understood. And let's get the word out that there's hope for recovery with therapy. So thanks so much, and I'll see you next week.